Hello, everybody. My name is Antoine Schneider from Switzerland. I'm glad to talk to you about the best options for renal replacement therapy. So these are my conflicts of interest. So, as I'm sure you're aware, COVID-19 is associated with acute kidney injury, and particularly in those patients that are sick enough to be admitted to the intensive care units. AKI is a marker of severities associated with poor prognosis, and this is even worse in those poor patients that require renal replacement therapy, which is required by 10 to 20% of patients. For those of us who needs to look after these patients, renal replacement therapy in these situations of outbreak generates lots of challenges that we have to deal with. And I'm going to go through them and try to present you some suggestion of potential ways of dealing with these challenges. So the challenges are already on the organizational level because, of course, the massive simultaneous numbers of patients that are arriving requiring renal replacement therapy, the capacity of a unit to administer the therapy might very well be overwhelmed. First, because there's not enough device, or more likely because there's not enough fluids or consumables. And so we need to make everything possible to optimize the devices and the consumables that are available. In addition to that, these therapies and this increased number of therapies have to be administered by a staff that's on average less trained. So some nurses, some doctors also are coming from other wards to help out on the COVID wards, and they are probably not used to administer renal replacement therapy, creating new challenges. And of course, this all happens in a situation of high level of stress, where even the staff is worried for their own safety. They have to deal with new techniques, so it makes it all very complicated. In addition to all this, these organizational issues, there are some technical issues related to the virus itself, and of course, its propensity to generate a coagulopathy and a inflammatory state, which together would lead to filter clotting, clogging, and therefore decreased filter life, and therefore making the problem even worse for the staff. So how can we deal with that? How can we improve the situation? Of course, the best thing is to educate everybody, make everybody comfortable with the therapy. In the vast majority of cases, we won't have time to deliver this education, but perhaps the way to go is to try and have as simple as possible protocols, very brief, that can be distributed and that can be used and to free the staffs from complicated issues. Really simple protocols, simplified, trying to allocate the patient with RT to nurses that are already used to the therapy, of course, as much as possible, and probably not try to avoid to introduce new techniques at the time of the outbreak, because it's probably looking for complications. But then once we've gone past that, the other things that we can deal with is when to start the therapy, how to end it, who to administer the therapy. And obviously the therapy, the renal replacement therapy, based on the literature, is associated with a very high mortality. So patients that will require renal replacement therapy might be patients for which we need to consider if they have other comorbidities, they are very old, and perhaps you need to decide not to administer the therapy. But that's something that you have to do according to your own beliefs, the situation, discussion with the family, and try to stick as possible as what you would do in normal situation, of course. The good news comes from the timing for the initiation, because in the midst of this coronavirus issue, we have received the good news from the START AKI trial that have demonstrated and confirmed data from other trials published in the recent years, that there's no benefit of initiating renal replacement therapy before life-threatening complications occur. And this large randomized control trial conducted over more than 15 countries have demonstrated no benefits in terms of mortality to initiate earlier the therapy. So that's good. We can start only when the patient really need it. We don't have to worry about starting earlier, but we still need to decide which modality and how to administer the therapy. So I would take for as a basis that the majority of units, at least throughout Europe would be using a continuous renal replacement therapy as a base, as a standard therapy. And maybe for those units who do, they should probably consider because we can't increase the amount of machines and the consumables, to perhaps request some helps from our colleagues from nephrology and get some intermittent hemodialysis devices in the unit with reverse osmosis. You don't need a purified water circuit to be able to run the therapy. IHD in these conditions might be an additional tool and enable to treat more patients. It's less likely to, it's less sensitive to coagulation because of the shorter filter life. Of course, it's associated with less cost. And the main advantage is you can then increase the number of patients you can treat per day. So here you probably want to combine the two therapies, perhaps switch earlier than you would to intermittent as much as possible. Then the question of the dose comes next. If you're going to do a therapy, then we have learned in the last 10 years that there was no benefit of increasing the dose of continuous renal replacement therapy above 25 mils per kilo per hour, or the equivalent of this. But then the next question is, can we go lower? And in this situation, this is probably something you would be asking yourself. Can I go lower with that? And there's no real data to support that it's safe to go under 25 mils per kilo per hour. So I would suggest as much as possible to try and stick to these doses. Perhaps it might be that it's safe after that, after 24, 48 hours, once the majority of the metabolic issues have been, but there's no real data. So I would encourage you to try and stick as possible with these recommendations. Then what we can do is try to optimize what we have and try to make our circuits last as long as possible and to increase or optimize the filter lifetime. To do so, there's a few suggestions that I can provide. And the first of those is really to have the best vascular access. As you probably know, the vascular access is the most important component of the renal replacement therapy circuit. It is also the most critical to issues. So a bad catheter will lead to early clotting, to early circuit failures, and therefore will really increase the nursing workload and the cost, and waste lots of disposals. So if you have a good catheter, which is a large, the right size, the right position, and in COVID patients that we're going to prone very regularly, you need the position of the catheter. It's all the more critical. So the recommendation is to use the right internal jugular, which is a straight direction, straight line to the right atrium, and avoid or minimize the use of femoral lines that are more prone to kinking when you're mobilizing the patients. In those patients that have a VV ECMO, you can consider direct connection, although this needs to be really done with lots of care and should not be the default connection, I guess. The next step is anticoagulation, extremely important in these coagulopathic patients. And here again, any form of anticoagulation would be good. You want anticoagulation, but the best anticoagulation, and this is also shown by randomized trials, is citrate regional anticoagulation. This is data from my center, and we've been able to demonstrate a much longer, it's not randomized, this is observational, and this is real life data, close to 4 times longer filter life with a CVVHD with citrate compared to heparin anticoagulation. So this is consistent with the current recommendation to try and use citrate. Then the question is, in the midst of the crisis, should we move to citrate? Probably not. I mean, citrate is also associated with issues, there's complications, you can have intoxication, you should probably not give it to all the patients. But for those units like in Europe, where now we might be in between two waves, it might be the right time now to implement citrate while we can. We have the time and the facility, anticipating for a potential, which I of course don't hope for, a new wave coming up. In terms of modality, in terms of what type of CRT, I would suggest to use CVVHD, continuous veno-venous hemodialysis. First, because it's associated with low blood flows. It requires only low blood flows, which then requires less citrate and less risk of citrate complications. There's less strain of the catheter. Then because you do hemodialysis, the amount of hemoconcentration, because the ultrafiltration is so low, is much lower, so the risk of clotting is also decreased. You don't need to use pre-dilution, so wasting a bit of the dose. The clearance is very good, at least for the molecules that really matter in the normal patients, and there's less tendency of protein cake formation clogging, which is known to occur in CVVH mode. And now there's data from the team of RENAL de Bellomo in Australia, and they've shown in this also observational study that the circuits run without anticoagulation, but in CVVHD mode, had a longer filter lifespan compared to those run in CVVH mode, confirming the hypothesis that I just made. Then finally, you can see the platform, the renal replacement therapy machine as a platform to administer renal replacement therapy, but also some associated therapy, such as SCOF, CO2 removal, MARS, or cytokine removal. And this could be particularly attractive in the situation of COVID patients, where we know they have this cytokine storm. There is a rationale to restore the tissue-blood gradient. We know that dexamethasone is most likely efficient. Tocilizumab might be too. These molecules decreasing the inflammatory response might improve the prognostic of the patients. Of course, there's no hard evidence, and it's just some rationale that this could be useful. On the contrary, CO2 removal to support lung ventilation could be also attractive as on a theoretical point of view, but the problems is that are technical, and it requires very high blood flow to have some form of efficacy. So as far as I know, it's difficult to run, and probably you're better off with an ECMO, veno-venous ECMO in the majority of patients. So that brings me to my conclusions. In those situations of limited resources, such as an outbreak of COVID, CRT, among other things, of course, must be optimized, and that includes adequate patient selection and adequate timing for initiation, adjusting the therapy to increase the filter lifespan as much as possible, adequate vascular access, anticoagulation, and if possible, regional citrate anticoagulation. And again, I suggest to use CVHD modes for all the reasons that we've discussed. And in addition, combine CRT with intermittent dialysis as much as possible according to your availabilities, and consider adjunct therapies in special situations. Thank you very much for your attention.